Alrighty, I'll take it away. Yeah, thank you for inviting me here. My name is Christiana Folks. I'm a research specialist at the UW Tele-Ophthalmology program, and I am joined here with our director, Dr. Yao Liu, to present our work in Milwaukee, advancing eyesight in African American communities. I just want to start off first by talking about, since we are a tele-ophthalmology program, the urgent need for tele-ophthalmology. Diabetic eye disease is the #1 cause of blindness in working age adults in America. And unlike other eye diseases, early detection and treatment prevents 90% of that blindness from diabetic eye disease. However, only half of adults with diabetes get yearly recommended eye screening. These are the national statistics, and I think it's really important to also talk about what it looks like for Black Americans. And what we found is that it's very important that Black Americans get diabetic eye checks, because Black Americans are 2 times more likely to develop blindness than non-Hispanic whites, as well as 50% more likely to develop diabetic eye disease. Compared to that 50% average nationally that I talked about, only 30% of Black adults with diabetes obtain yearly eye screening. And more than 1,200 of Black adults with diabetes in Wisconsin suffer avoidable blindness. Tele-ophthalmology can really help with those statistics. How it works is a patient comes into the primary care office, they're tagged for not having diabetic eye screening in the last 2 years or a year or so, and they go to the camera and photos get taken in the same building on the same day of that appointment. Those images get sent to Madison and are read by UW eye specialists, and either 2 things can happen. That patient has is identified for further clinical evaluation and treatment and get referred to a local eye doctor, or their eyes are fine and they're told to do it the next year. Tele-ophthalmology is very beneficial for patients. It's very convenient. Again, it can happen in the primary care office on the same day of that appointment. There's no dilating eye drops, so it's super comfortable, and patients can wear their contact lenses. It's also fast, 10 minutes or less to image both eyes, and low cost. $0 to $30 out of pocket. It's covered by many insurance, compared to what you would expect at Walmart or Costco, which you're looking at $50 or $60 for an exam. Ultimately, tele-ophthalmology expedites eye clinic appointments for patients with vision-threatening diseases. As you're probably imagining, if tele-ophthalmology is so great, why don't we see it everywhere? Well, what we found is that primary care referrals aren't happening. And so a patient comes into the primary care office, they aren't tagged or alerted that they need screening, they aren't referred to get their photos taken in that building, and the process isn't happening. And so primary care referrals are super critical to this process. As you can see here at this multi-center study done in 2015, looking at the long-term effectiveness of tele-ophthalmology, screening rates never exceeded 55% after 6 months. And so what our program decided to do was create an intervention sustaining the effectiveness of tele-ophthalmology. And what we did is a pilot study at Mile Bluff Medical Center. Mile Bluff Medical Center is located in Madison, Wisconsin, serving 2,200 patients with diabetes. It's ranked 68th out of 72 counties in Wisconsin. We placed a camera in the main primary care clinic building, as you can see here on the right, and it serviced 4 other sites, and partnered with local eye doctors to provide care when needed for referrals. Our goal of this pilot study was to increase diabetic eye screening rates using tele-ophthalmology throughout rural Wisconsin, and to increase screening rates to a goal of 70% or greater, which would have us in the 90th percentile. Our aims of this research pilot study was first to conduct interviews with patients and key stakeholders to identify barriers and facilitators to tele-ophthalmology use, and then use that information to develop and test an implementation package to increase tele-ophthalmology use within Mile Bluff. That became eyesight, which is the implementation for sustained impact in tele-ophthalmology, and it was adapted after the NIATEX model, which was developed by UW researchers as a well-established systematic healthcare process for improvement. After implementing eyesight at Mile Bluff, what we found was that there was a huge increase in diabetic eye screening, over 60% compared to their starting rate at 47.4%. Also, we found that even 3 years later after the implementation, we were still looking at 64.1% in 2019, which is near our target of 70%, which would have us at the 90th percentile. As you can imagine, after 2019, the pandemic in 2020 decreased in-person patient visits to the primary care office, which in turn decreased our tele-ophthalmology rates, but we're currently working now to get those higher. And now what I will be presenting on the rest of our time here is what we're currently doing. We're working to culturally adapt eyesight that we worked on at Mile Bluff for Outreach Community Health Centers in Milwaukee. It's a federally qualified health center serving urban low-income Black patients. They're ranked 70th out of 72 counties in Wisconsin, and their current diabetic eye screening rate is 7%. It's also really important to note that their social vulnerability index, SVI, was found to be 0.88 for that census tract at Outreach Community Health Centers. SVI uses census tracts to rank each tract on 16 social factors, including poverty, lack of vehicle access, and crowded housing. The scale is from a 0 to 1, and so Outreach being at 0.88 means that they're less than 2 markers away from being the most socially vulnerable that a census tract can be. So what we ended up doing for this project, which was different from our prior pilot study, was let implementation mapping inform our process for cultural adaptation and the aims of our research. Implementation mapping is an intervention mapping protocol for planning implementation strategies. And as you can see here, there's 5 tasks compared to those 2 aims that we had before. And those 5 tasks ask, who are we? What's our patient population? The who, what's their needs and assets? The what, the why, and the how, which is developing and selecting implementation strategies. And what we will work on in the future is task 5, evaluating our program and those implementation strategies. So our goal for this project, Outreach Community Health Centers, is to expand tele-ophthalmology use to reduce preventable blindness from diabetes in Milwaukee. As you can see here, we have our 5 tasks, and for the point of this, our main focus is going to be task 1 and task 3. Task 1 being conducting needs assessments, and how we did that was do patient interviews, clinical personnel interviews, as well as a community advisory board meeting. And for task 3, we selected implementation strategies, collaborating with community advisory board and a subset of interviewees from our patient interviews. So focusing just right now on task 1, conducting needs assessment, we interviewed 21 Black patients and 11 clinical personnel from Outreach Community Health Centers about diabetic eye checks. We asked them what makes it hard to get diabetic eye checks and what makes it easier to get diabetic eye checks. And what we found was that there were a lot of factors influencing patients' adherence to diabetic eye screening, but more importantly, there were temporal relationships between factors influencing screening relative to patients' interactions with healthcare. And so we decided to use a systems model of clinical preventative care to visualize this process. The systems model of clinical preventative care is a model focused on patient-physician's relationship that was first proposed in 1992 that we adapted here for our study findings. Now I just want to focus on the barriers that we found to diabetic eye screening. Barriers included poverty, financial trade-offs, limited health literacy, and a lack of availability of services, including a lack of insurance acceptance, long wait times, as well as poor community infrastructures, which included transportation difficulties, a lack of housing, and a lack of healthcare clinics. Taking a closer look at facilitators that we found in our interviews, our patient and clinical personnel interviews to diabetic eye screening in urban Black communities. Facilitators included social functioning, positive social functioning. So we saw family peer support, community experiences with diabetes complications and advice on that, and positive patient and physician relationship. Now focusing mostly on interview themes that we found were unique to our patient population as well as complex. I want to take a closer look at the first theme, which is lack of trust in healthcare, which is a major barrier and a prominent barrier that we found in interview results. As you can see here, a patient said, people build up walls to keep themselves safe. You know, I don't like hospitals is one reason they don't go get checked or they don't prioritize their health. Historically, the government has done a lot of experimentation on African Americans, referencing the Tuskegee syphilis experiment. That's another example. There's just some mistrust or a lot of miseducation, but there are factual occurrences that the government has done, you know, experiments on us. We found that medical mistrust was a very emerging theme in our interview results. And I think it's really interesting because while it was reported, I think in the wider literature, I don't think medical mistrust or lack of trust in healthcare has been as widely reported in telemedicine and diabetes literature as a very influential factor for Black patients getting screening using tele-ophthalmology. The next theme I want to talk about is another barrier, a very unique barrier to this patient population in Milwaukee, which was lack of transportation, vehicle access. One patient says, now you got to walk places to get your eye checks, take your eyeglass prescription to another place, and then that's too much. Eye doctors should get an office where your primary care doctor is. People don't have transportation. It's a lot. It's just too much. I think this gives a lot of insight into the community infrastructure of Milwaukee versus other major cities, only because other similar studies did not report transportation as a major barrier, as we saw with patients here. Another complex theme that we found in interview results was religious faith. Interestingly enough, it was found as mostly a facilitator. Speaking to the CAB and our subset of interviewees, we found that oftentimes it could be a barrier for patients, but we found that religious faith acted as a way of guidance, a resilience for patients. As you see here, a patient says, I take my medicine every day. That's the most important thing in my life. I ask God to guide me. Sometimes I'm scared to take insulin. So we found that belief of God, again, was just contrasting to other studies citing religious faith as a barrier. It was a major facilitator for patients to get diabetic eye screening. Another barrier that we found was legacy of segregation. One patient says, I hate to put this on there, but I just have to tell the truth. We were divided, we were separated. The Blacks lived on the west side of town and the whites lived on the east side of town. When you go to the hospital, sometimes they just don't want to accept you. You could feel the tension and you see it, so you didn't go. Again, Milwaukee is one of the most segregated cities in America, and so you can see how the legacy of segregation continues to affect patients' ability to go get screened for diabetic eye screening. And I thought that was really interesting as well, and how it's shaped the way that Black patients still continue to get care. Another prominent theme that we found was adverse life events and prioritizing your own health. One patient says, it came to a point that I had to start taking care of me. I was always taking care of other people. I took care of my mom, my dad until they passed away. I took care of my granddaughter until she passed away at age of 13. Then it took me like 2.5 years to kind of like get myself back together. And so we found that adverse life events, traumatic events, and the stress that was put on patients affected their way to prioritize their own health. I think this is really important to note, as adverse life events are more often experienced by Black patients, as you saw previously, due to SVI, being socially vulnerable. And so it's really important for providers to be aware that their patients may be going through adverse life events and having a hard time prioritizing their own health. A next theme that we found was the importance of self-advocacy in healthcare. This was also a barrier to patients. We found that patients had to be an advocate for themselves and very resilient in order to get their care. One patient says, I get through to my doctor because I keep irritating the receptionist, then I make threats, I'm not gonna lie, and then they put my doctor's nurse on the phone. Another patient says, I make an appointment, or I'll walk up to the clinic or have my caregiver take me, and I'll sit there until they see me. I only live around the corner. I'll have someone take me around and sit there until I'm seen or get what I want. This is really important to note as we're talking about patients that may have adverse life events, on the other hand, and struggling with mental health or physical challenges. And in order to get diabetic eye screening, patients are required, again, to have a lot of resilience and be an advocate for themselves. Lastly, for a theme that was unique that we found in our interviews, was preference for alternative medicine, also known as home remedies. A patient says some people go off superstitions, some was raised to do home remedies. Another patient says, being from the old school, parents did not take their children to the doctor regularly because they couldn't afford it. You only went during an emergency. You were raised that way. It got to be a part of you. You just don't go to the doctor. Again, I think this shows how the legacy of historical events, the legacy of segregation, and institutional racism is still affecting the way that Black patients get their care and their ability to get screened for eye screening. So the preference for alternative medicine instead of Western medicine, or going to go see a doctor, was a prevalent barrier in our themes or in our interviews. Now moving on to task 3 of our implementation process, selecting implementation strategies. We conducted 60-minute virtual meetings with the CAB, Community Advisory Board meeting, or advisory board with 11 members, as well as a member check-in with 2 patients to present our preliminary findings and identify implementation strategies. The CAB was Black and Milwaukee-based, specializing in providing population-related feedback to research projects. And basically, in those 2 meetings, we asked, how can we make it easier to get diabetic eye checks? And what we found for strategies was that we grouped them into 3 categories. Strategies were chosen by stakeholders to specifically address factors that arise prior to healthcare and your interaction with healthcare. For example, patients that were getting care for the first time, or thinking about getting care for the first time, or for the first time in a long time, again, referencing back to people who weren't able to prioritize their own healthcare and hadn't gotten care in the last couple of years. Then also, strategies were chosen by stakeholders in the Community Advisory Board to specifically address factors that arise while connecting to healthcare. By that, we mean people who are trying to get booked for an appointment, trying to actually get to an appointment through transportation. And then stakeholders chose strategies to address factors that come up for interacting with healthcare, which is talking about patients once they're actually in the clinic, they're interacting with clinical personnel and the factors that arise during that process. And what we found was that strategies to address factors that arise prior to healthcare, chosen by stakeholders, was patient education, motivational messaging, and support from trusted messengers, as well as free diabetic eye checks at health fairs for underinsured. We found that strategies addressing factors connecting to healthcare were patient reminders about diabetic eye checks and financial support and incentives. And then we also found that strategies chosen by stakeholders to specifically address the factors that arise while interacting with healthcare were clinic policies supportive to patients with adverse life events, and training clinical personnel about patient experiences with racism and discrimination. Our next steps in our process, again, task 5, we still need to evaluate and measure the impact of these strategies, as well as develop and test the strategies in a tele-ophthalmology program at outreach community health centers that launched in March of 2023, just this past month. And we will continue to work with the CAB and outreach community health centers to develop strategies to increase diabetic eye checks. I just want to take a few minutes to just thank everyone that's been involved in this process, the CAB and our research team as well. And that's the end. Please let me know if you have any questions.
Thank you so much. That was such a great presentation. And it's such important work that you're doing. Can you talk a little bit about how your findings will be shared back with the community beyond the sort of like presentations to the CAB themselves, and potentially also with other healthcare providing systems within the city of Milwaukee?
I know that we're working on 2 manuscripts currently that will be published soon. One talking about the factors that we were talking about earlier in the presentation, the factors that arise while getting diabetic eye screening affecting or influencing Black patients, as well as publishing our implementation strategies. I am curious to know also what Dr. Yaolu thinks.
Yes, so great question, Heidi, and excellent presentation, Christiana. So we are actually actively working with Outreach Community Health Centers, which is the FQHC that we've partnered with, to actually use this information. We've actually, met with them to review this data already and get some of their ideas too, as part of our member checking process as well. And we're working on, actually putting these potential strategies into action. And so, the ones that are really clinic level specific, we're able to work with the clinic. The interventions that are the strategies that are related to kind of the more community-based things. So Christiana actually did all of these interviews with a church in the community that serves a predominantly Black population. And so the church has been very interested in partnering with us for their health fairs, to do screening within the community and potentially do some community-based education around eye screening and eye health. And so we're looking at different partners in the community. Another group that we've been encouraged to work with is a Black-owned barbershop known as G's Clippers in Milwaukee, and they're in the same neighborhood. And they are very well respected in the community, and they're already doing some health-related counseling, particularly for Black men who are an especially difficult group to reach. And so, there's just a lot of organizations within the community that we can potentially partner with to kind of get the word out, get people knowledgeable and interested in screening, to get them into these programs. I think other things related to the logistical barriers, I think just, connecting people with social workers, patient navigators, those types of programs to kind of help people overcome a lot of the barriers that are really structural, so that we're addressing both sort of the trust issue by working with the community and trusted voices in the community, as well as working with resources to help overcome a lot of these logistical barriers, as well as with the clinic. So it's sort of, multiple different levels of intervention at the patient level and at the community and clinic level.
Would there be a role for bringing the, like, I don't know how feasible it is, but would there be a role for the tele-ophthalmology machine to be in a place that's not a healthcare setting, or is that not feasible?
So we've used the camera in health fairs in rural Wisconsin, and it's very, portable into any space with a connection to electrical outlet. I think we can do that. I think in terms of leaving it someplace, we've talked with, a pharmacy chain in Milwaukee that serves a lot of underrepresented communities there. And I think the cost right now and the volume, it's hard to justify, just because even though obviously diabetes plays a huge role in our world, it still is only about 10% of the population. So it's not that common. Like even in a primary care clinic, the average primary care doctor might see like maybe 2 or 3 diabetes patients in a day. So it's not that, it's hard to get a high enough concentration of people on a regular basis to kind of leave it somewhere in the community, unless it's like specifically for like diabetes education or, somewhere that people congregate. Like even a pharmacy probably wouldn't be high volume enough. But I think health fairs and using it as a community education tool as well as a screening tool, I think can be really helpful. And the other piece is obviously partnering with local eye doctors, because it's not enough to screen people. You actually have to get them into care, and that can be its own challenge.
It just strikes me that tele-ophthalmology, like that since transportation is such a big barrier, that, there, if you've got portable technology and it really is that portable, then it seems like there could be ways to overcome that barrier. I understand it's low volume, like on any given day, and maybe it is, but maybe even like bringing it to, yeah, I don't know. I'm brainstorming here, but I'm just thinking, like, it sounds like there are given tele-ophthalmology is a portable thing. So a lot of those barriers, I feel like you could meet people where they are in some regular way. I don't know. And I don't know about how complicated it is to connect with health systems and get the data from the tele-ophthalmology, from the camera into their healthcare. But it just seems like you have the tools to do this.
Yeah, I think as with many things, we have the technology, it's the details, right? So then it's like, well, who's going to pay for it? And the camera is expensive, and how do you bill for it? You need enough volume so that the imager can be, knowledgeable about how to do the imaging. And then getting the images uploaded somewhere. So there have been a lot of community-based programs that have tried to do this, like for, charity clinics, and it's been hard to get those scalable just because there's just so many logistical barriers to making it sustainable. And that's why we've sort of stuck with using health systems, particularly at QHCs that have patients regularly going to them, and the staff and the space and the billing capability to make the program sustainable. But yes, people have thought about, let's just have a kiosk in the mall that does comprehensive eye screening, and the technology is actually pretty feasible. It's just, again, like who's going to pay for it and whatnot.
It sounds like there's important policy ramifications, and there is a policy consultant with UW. If you email the DNI Launchpad, well, or she may be Connie Schulze. She does policy consultations for SMPH and UW, and that might be really helpful because, it sort of comes back to, as part of reparations, we should be, our society should be paying for what is needed, which is extra to reduce disparities. and that takes policy.
Yeah, I just came back from an NIH workshop that was a collaboration between the National Eye Institute and the National Institute of Minority Health and Health Disparities. And, you know, we kind of talked about what are the opportunities to address eye vision, you know, health disparities. And we kind of, the running joke was like, you know, you can't talk about policy because obviously policy would fix so many of these problems, you know, related to paying for transportation, right? Making it easier for patients to get to their eye clinics, and then also having more eye clinics accept Medicaid patients, because they're just, the reimbursements are very low, and because they're administered at the state level, there's no mandate, unlike Medicare. So there's no requirement to see Medicaid patients. And so as a result, a lot of these patients are having to travel very far because there's so few eye clinics that will actually accept Medicaid patients, and then they get booked out very far. So there's just a lot of policy implications in terms of, you know, reimbursement as well that would help really drive adoption. So yes, the policy is sort of the big picture challenge. So we appreciate your sending us Connie's name. I think we are very lucky here in Wisconsin that we have a very relatively well-administered Medicaid program compared to a lot of other places. I'm reading a question from Molly Murphy in the chat. It's interesting that many of the facilitators you discovered are adaptive responses to unsupportive contexts, such as having strong self-advocacy that to facilitate, you know, and it becomes necessary because the system is not supportive of patients and Black patients in particular. I wonder how this could be accounted for in the messaging from trusted messengers and who those trusted messengers are. Christiana, did you want to take that question?
Yes, so actually we're working with the Community Advisory Board this upcoming week to talk about who those trusted messengers are and presenting those strategies that we selected with them again, and talking about how we can actually put these into practice, who we're going to work with, what it should look like. I think just from interviews and the community advisory boards that we've already done, trusted messengers, as Dr. Yalu talked about, that came up were barbershops. We found that the church that we worked with was also, as I worked with patients coming into that church, that they were a trusted messenger at Grace Fellowship Church, as well as radio stations. So yeah, that's what we hypothesized, but we are working with them next week to really dig deep into how we're going to develop these and who we can work with and who those look like for in Milwaukee in particular.
Yeah, so in the diabetes and cancer and smoking cessation literature, it's pretty clear that having you know, barbers and barbershops are highly trusted, pastors, people in faith-based organizations, and educating those folks and empowering them to actually be part of the conversation in terms of helping patients advocate for their health needs and encouraging them seems to be very effective. And there's a lot of interest in that. And there's been many studies showing that it is effective. So how exactly that's going to look in our study, as Christiana said, we're going to be working with our community advisory board next week to really sort of put those plans into more concrete terms.
I was also thinking community health workers, because sometimes they are people from the community who sort of had some training, but they serve as trusted messengers too.
Yeah, absolutely.
Thank you for that. That's super interesting and great presentation, Christiana. One other question that I had was about, you know, you just mentioned smoking cessation, for example, and I was curious. I know for example, breast cancer screening, the apprehension, fear, wanting to just sort of not know about like what is the next step from there is a really big barrier to engaging in the screening itself. And I was curious if you heard anything from folks about that as a barrier, or, you know, like, so I find out and then what? Yeah, just curious. Thank you.
So the fear of what the results may be.
Yeah, and just next steps, you know, that healthcare is formidable to anybody.
Yeah.
And you know, finding out you know, for sure that you have to do something as a next step, or based on whatever you find in a screening, can be a big impediment to wanting to do the screening, or feeling like you're ready to do the screening even.
Sure. Yeah. I think that in our pilot study, I think that was found to be a prominent theme, the fear of like knowing. But I don't think in our study that was as prominent. I know that for sure burden of diabetes management was more of a prominent theme, less of like the fear of knowing what's going to happen, but the burden of it, of actually like having to manage your diabetes once it gets to a certain point and there's complications. And so we found in patients that there was a lot of like mental challenges of overcoming and like living with diabetes. And so insulin injection, yes, like we had a patient who was doing laser treatment with his eyes every week. And so the burden of diabetes management, I think, got to people a lot, and was a barrier to continuing to manage their diabetes. But on the other hand, I think that because of religious faith being such a prominent facilitator, that there was like the other side of it, that people were scared and fearful of their results or managing diabetes, but continue to persevere because of like God, because of belief in God, to continue to be resilient, and that like everything will eventually be okay as long as you keep moving forward. And so I think I was blessed to work with patients that gave me a lot of hope, because they were so hopeful as well.
I know that in Yinka Shiambola's work, who gave the last seminar, which was excellent, there's a lot of fatalism, I guess, in the Black community, where it's like, well, you know, why should I even try to manage these things when I just know that the outcome's going to be bad? And I think that sort of speaks to the avoiding the bad news, that, well, I don't think I'm going to have a good outcome anyway. So I think that that's really where, you know, getting messages out in the community from trusted messengers about, know that there are treatments, and, you know, things can get better, and you can kind of become, you know, and increase people's self-efficacy in terms of what they're able to do with their situation, I think is really important. And I think, you know, potentially, you know, in terms of motivational interviewing, and when you're doing sort of tailored or targeted, you know, messaging, those are all important points to be able to address.
I have one more question. We hear so much about influencers on social media. How do you think that could play a role here? Was there any sort of discussion about that?
That's such an interesting question. I think that the average age that we ended up for our interviewees was in the 50s. So I think it was 52 for the average age. So I think if we had more younger patients, I think that would be something that was coming up. I think the youngest patient that we had was 27. But I do imagine that if we were to do or focus really on strategies or factors that were influential to younger people with diabetes, that could definitely be a trusted messenger. I think about plenty of like social influencers that are really important to my family. Like, and so I think that could be relevant. I don't know, what's your opinion? Yeah.
I would say it just depends on the demographics. So right now, most of the patients have type 2 diabetes and they're older. And so I don't know to what extent they're using social media compared to the younger crowd. I think, if you're really focusing on the type 1 diabetes, which is a relatively small group of people, relative to the type 2 population, but they have the greatest burden of disease because of the severity and early age of onset. I think they would be a potentially helpful resource. I don't know if other fields have used like influencers in a health related context. I'd be curious if anybody's familiar with that.
I think the other thing that's kind of interesting about it, and I'm not sure if this would work or backfire, but children encouraging their parents to, the ability of children to say, Mom, Dad, get your eyes checked, But I know children don't listen to parents, so maybe parents don't listen to children.
It does strike me, though, that a lot of these suggestions are like putting the onus on the individual, when a lot of the barriers that you uncovered will not be overcome by more messages to the individuals.
Mm-hmm.
It didn't sound to me like the major hurdle was not knowing about the importance.
I had the same thought, Heidi, both in terms of, an equity lens and, just never wanting to frame a structural problem as an individual's responsibility to fix and take on themselves. But I was also just curious about it because Christiana, I think it was actually the preceding study that you were sharing, but that the most fundamental roadblock was that the referrals weren't happening in the primary care settings. So I guess my mind went to like, well, then the individual where there's a link in the chain is not the patient. That's not the onus is not on the patient to make that referral. It's on the provider, right?
For sure. Yeah. I think most of the strategies that I shared today were patient related, but we definitely have strategies that we're going to be working with outreach that are provider and clinical personnel related. Some that come to mind is, again, designing clinic policies that are flexible to patients and providing clinical personnel with like motivational interviewing and scripts that are culturally adapted, as well as training them in racism and discrimination and just patient experiences and presenting our work to them. But that's definitely something that we've thought about. And I think that because our patient interviews and our CAB is focused on asking them for strategies, I think that a lot of them that were suggested are patient related. But inherently eyesight is an implementation package that is done in the clinic and is working with clinical personnel and their staff.
Yeah, I think just building on that, like, most of our focus has been on the clinic and getting, the primary care staff and clinicians to order the testing. And that's been very effective because most of the time people really trust their primary care person, and that, even if they don't understand why they're getting the testing, they are very willing to do it if it's strongly recommended. So that's good. I think in this community in particular, because there's so many issues with trust and people not regularly seeing their primary care clinician, not being happy with their primary care clinician, I think focusing solely on the clinic doesn't seem like it would be as effective. I think as Christiana mentioned in her talk, there's sort of multiple different populations of people. There are people that are, seeing their doctor regularly in primary care and just, don't know about or haven't, gone and gotten their eyes checked. Then there are people who intermittently use healthcare, and then there are people who just want nothing to do with healthcare. And I think being able to address, those different populations with multiple different strategies, I think is really important. And, we certainly don't think that there's like one major, I think that that's the thing that we're fighting against, right? That we really need systems level, multi-level interventions, that it's not just, oh, we just need to educate people and then, magically everything's going to get better. I think that's really the key message with a lot of the work that we and others are doing.
Just curious, Anne has a comment, but one thing one of your participants suggested like putting the eye stuff in the primary care location. Is that something, is there a model for that where people could like get their pictures taken and get their glasses in one of the FQHCs in the city of Milwaukee?
So I don't know about in Milwaukee, but that there's a CDC project right now where that's what they're doing, is they're actually doing comprehensive eye care in FQHC primary care clinics. And that's a model that's been well established at the VA by April Ma's work in Emory, where basically rather than referring everyone to these eye centers, you actually have staff who are trained to do all of the, checking your glasses, taking pictures, and having remote evaluation by a physician and located in another place, do all of that. The CDC project led by Pollyann Newman-Casey at the University of Michigan takes it to the next level, which is that after they give the patient the prescription, the technician is actually trained to help them log on to websites where they can buy glasses, and it actually helps the participant, the patient, actually order glasses online, which can be, for very, relatively inexpensively. And so I think that's one of the really big, problems, is that if you give someone a prescription, well, they don't have the money to buy the glasses. And if you tell them go online, a lot of the older patients don't even know how to buy something online. And so having that extra step of, no, we're actually going to help you order the glasses online makes a big difference. And, at our free clinic here in Madison, where we see patients who can't afford to pay, we actually can give them glasses that same day based on donated glasses that are very similar in prescription. So there's not even like the wait time to make the glasses. And that's a model that's been used throughout the developing, low and medium income countries because of the need. Just get everything done that day while they're still there.
And you want to bring us home?
Yeah, thank you. I'm curious about, for those individuals who don't necessarily have a strong relationship with a primary care provider and go intermittently for healthcare, I'd be interested if is there less of motivational interviewing? I know that that's relied upon for so many different kinds of interventions. And I'm more familiar with the world of nutrition than health equity, but I'd love to know more whether there's evidence that is truly successful.
I think there's a lot of literature in the smoking cessation literature about the usefulness of motivational interviewing in terms of helping better assess what are the key, drivers for people, because it really varies. And then being able to address those particular things. As I said, I was in this workshop earlier this week, and there was somebody who was an expert in communication, and he was saying that the reasons people smoke, how they smoke, why they smoke, when they smoke, it really is completely different depending on the population that you're studying. And there's actually, quite a lot of concordance based on race and ethnicity and age and all these things. And then how you convince somebody to stop also depends on like their belief system. And so there's quite a literature on like how you do tailored messaging based on how people, their belief system, not just who they are, but what they believe. And he showed us some really fascinating messaging that they had tailored, for Black patients, those who had a real sense of, like those who wanted to hear about Tuskegee, those who did not want to hear about Tuskegee, people who wanted to talk about, you know, the strength of their ancestors, people who wanted nothing to do with, like, you know, Africa and like African history. You know, it was just really fascinating how they were able to get in touch with what are people's worldviews beyond just your demographics. And I thought that was super cool.
Yeah, that takes a commitment and a willingness and some time, you know, for someone to develop those kinds of skills. So, so like I said, I'm particularly curious about the success with those who intermittently go to the clinic. So, but thank you so much. That's helpful to know.
Well, please join me in congratulating and thanking Christiana and Yao for today's presentation and discussion. It was absolutely wonderful. We're so grateful to you for joining us, and the recording will be available on our website. Please take a moment and complete the survey. I dropped a link in the chat. We do listen and try to improve this seminar, and it is a new one, so your feedback is particularly important.